Good morning, viewers. Thank you for joining me today. I am Nurse Nancy and it is my pleasure to be with you here in the studio. Today I will be giving a health talk on postpartum hemorrhage, is one of the commonest causes of maternal deaths in the world today. Postpartum hemorrhage is excessive bleeding following childbirth, typically defined as the loss of more than 500 milliliters of blood after vaginal delivery or more than 1,000 milliliters after a cesarean section. Postpartum hemorrhage is a leading cause of maternal mortality worldwide. This is especially so in less developed countries where lack of delivery facilities and poor health status of women prevail, but it is preventable and manageable with timely intervention. Postpartum hemorrhage or bleeding after birth is an important obstetrics emergency and demands prompt diagnosis and treatment. Postpartum hemorrhage can be primary or secondary. Primary occurs within 24 hours of delivery and secondary postpartum hemorrhage occurs if bleeding in excess lochia occurs after 24 hours of delivery but before the end of puerperium, that is 6 months after delivery. Primary postpartum hemorrhage is by far the more frequently encountered and the most severe in consequences. Risk factors includes multiple pregnancies like twins, triplets, etc. Prolonged labor or very quick labor, previous history of postpartum hemorrhage, high parity, that is, having given birth many times, induced labor, use of certain medications like oxytocin or magnesium sulfate used for management of preeclampsia and eclampsia, anesthetic like chloroform, beta-symptomatic drugs used for uterine relaxation, large baby or macrosomia cesarean delivery. Causes of primary postpartum hemorrhage includes uterine atony, which is the most common cause, resulting when there is failure of prompt and sustained uterine contractions during the third stage of labor. Simply the uterus fails to contract after delivery. Uterine atony happens when there is inefficient uterine contractions following delivery of placenta, thereby resulting to unremitting bleeding into the uterus from placenta site. Its risk factors are full bladder, excessive uterine distension, etc. Retained placental tissue. Pieces of the placenta remain attached to the uterine wall, preventing the uterus from contracting properly. Other causes of primary postpartum hemorrhage are trauma, which could be injuries to the birth canal, including lacerations or tears in the cervix, vagina, or perineum. Coagulopathies, which involves disorders affecting blood clotting, either pre-existing or acquired during pregnancy. Uterine rupture, a rare but serious condition where the uterus tears during labor. Other causes of primary postpartum hemorrhage includes uterine inversion and amniotic fluid embolism. Secondary postpartum hemorrhage is said to occur when there is vaginal bleeding in excess of expected lochia after 24 hours, but within 42 hours of delivery. Normally for the first few days following childbirth there is rapid diminution of vaginal bleeding in quantity and color. By the fourth day the lochia transits from rubra, which is red, to serosa, which is pink lochia that lasts between 2 to 3 weeks. After that changes to lochia alba, which is white lochia. Therefore any bleeding in excess of this pattern should be examined and investigated for retained placenta and endometritis or secondary bleeding from surgical wounds. Prevention of postpartum hemorrhage involves active management of the third stage of labor, administering uterotonic drugs, example oxytocin, immediately after delivery to help the uterus contract. Controlled cord traction to help deliver the placenta. Uterine massage after the placenta is delivered. Identifying and managing risk factors early in pregnancy and labor. Ensuring careful handling of the placenta and birth canal during delivery. Management of postpartum hemorrhage involves the following: immediate response, call for help immediately. Monitor vital signs closely. Start intravenous fluids to maintain blood pressure and replace lost fluids. Administer uterotonic drugs to encourage uterine contractions. Perform uterine massage to help the uterus contract. Check for and manage any retained placental tissue or birth canal trauma. Advanced interventions, blood transfusion if there is significant blood loss. Surgical interventions such as uterine artery ligation, uterine packing, or, in severe cases, a hysterectomy. Post-event care, close monitoring in a health care facility for at least 24 hours post-delivery. counseling and support for the mother and family. In-depth preventive strategies involves the following: antenatal care, screening for anemia and treating it effectively can reduce the risk of PPH. Identifying and managing hypertensive disorders, which can lead to coagulopathies. Educating the mother about the importance of delivering in a healthcare facility with trained personnel. Active management of the third stage of labor, Amtsel, uterotonics, drugs like oxytocin, misoprostol, or ergometrin are administered to stimulate uterine contractions. Oxytocin is the preferred drug due to its effectiveness and safety profile. Controlled cord traction. This involves gently pulling on the umbilical cord while applying counterpressure to the uterus to help deliver the placenta, reducing the risk of retained placenta. Uterine massage. After placental delivery, the uterus is massaged to ensure it remains contracted, preventing atony. Blood banking and transfusion protocols. Having a well-organized blood bank with readily available blood products is crucial for managing severe cases of PPH. Establishing protocols for rapid blood transfusion and emergency surgery can save lives. Advanced management involves the following: balloon tamponade. A balloon is inserted into the uterus and inflated with saline to apply pressure internally, helping to stop the bleeding. This is an effective, minimally invasive technique used in cases of uterine atony. Surgical interventions. Beelinch suture, a special suture technique that compresses the uterus and helps control bleeding in cases of uterine atony. Uterine artery ligation. Tying off the arteries that supply blood to the uterus can reduce blood flow and control hemorrhage. Hysterectomy. In cases where all other measures fail, a hysterectomy, removal of the uterus, may be necessary to save the mother's life. Use of tranexamic acid, XA. This medication helps to stabilize clots and reduce bleeding. Recent studies have shown that early administration of XA in PPH can reduce maternal mortality. Long-term effects and counseling are physical effects. Severe postpartum hemorrhage can lead to anemia, fatigue, and delayed recovery post-delivery. Emotional and psychological impact. Experiencing postpartum hemorrhage can be traumatic, leading to anxiety, depression, or post-traumatic stress disorder, PTSD. It's important to provide psychological support and counseling to affected women. Future pregnancies. Women who have had PPH in a previous pregnancy are at higher risk in future pregnancies. They should be closely monitored and counseled on the importance of delivering in a well-equipped healthcare facility. Awareness on postpartum hemorrhage should focus on training healthcare providers, ongoing education and training for midwives, nurses, and doctors on the early recognition and management of postpartum hemorrhage. Community education. Educating the community, particularly in rural areas, about the importance of skilled birth attendants and the dangers of bleeding after birth can improve outcomes. Emphasize preparedness. Healthcare systems must be prepared for postpartum bleeding with protocols, equipment, and trained personnel ready to act. Collaboration. Encourage collaboration between obstetricians, midwives, nurses, and other healthcare providers to ensure a coordinated response to postpartum bleeding. Empower women. Educate women on the importance of antenatal care, recognizing signs of postpartum bleeding, and the need to seek immediate help. Thank you for listening. I am still your favorite nurse and midwife, Nancy.